everyone. Thank you so much for joining the webinar today. Hold on one second. We're just having a little difficulties. Okay. Thank you so much for joining today. My name is Melissa Barron, and I'm a program manager at the Center to Advance Palliative Care, which manages Get Palliative Care. Welcome to today's webinar, Living with Ovarian Cancer, How Palliative Care Can Help, with Dr. Beth Popp. Thank you again for joining today. Before we begin, a few things to note. If you are having any technical difficulties, please make sure to dial in to the number on the right side of your screen. It should be under the audio section of your GoToWebinar panel. If you have any questions that you would like to have answered as we go through the session, please type them into the question section of your GoToWebinar panel, and it will be addressed during the Q&A question and answer portion toward the end of today's webinar. I will now turn it on over to Dr. Beth Popp for her presentation.
Good morning. Thank you, Melissa, and thank you to everyone who's joining us. I am speaking to you from the Upper East Side of New York, where we have a very picturesque little snow going on. And I'm happy to get to spend a few minutes with you this morning, and actually over the next hour, to talk to you about how palliative care can help those who are living with ovarian cancer. And we'll be able to take some questions from you towards the end of the presentation. Next. What we'll do over the course of my prepared comments is to clarify and define what palliative care is and who can benefit from it, how palliative care can enhance the care of women who have ovarian cancer, some of the most common questions that patients ask, and then, as I said, we'll have time for your questions. Next. So let's start with the most fundamental question, which is, what is palliative care? Palliative care is specialized medical care for people with serious illness. And it focuses on providing relief from the symptoms and stress of a serious illness. The goal is really to improve the quality of life for both the patient and the family. And while we refer to it as specialized medical care, it's really beyond what we traditionally think of as medical care, because it's provided by a specially trained interdisciplinary team, which means physicians, nurses, social workers, chaplains, and a variety of other healthcare providers who work together with the patient's primary healthcare team to provide an extra layer of support. Palliative care is really appropriate for people with a serious illness of any age and at any stage in the course of their serious illness, and it can be provided along with disease-focused or curative treatment. Next. Treating the pain and the symptoms and the stress of cancer and its aftermath is really just as important as treating the cancer. Next. Certainly to an audience of people who have experienced cancer in their lives, that's not something that you need to hear from me. While the oncologist may be most focused on treating the cancer, and that's what you want your oncologist to be focused on, the person who's living with the cancer has fatigue, may be dealing with weight loss, may be nauseous, have pain, be worried, and have a whole host of other issues on their mind and experiencing in their body. Next. So it's really not that complicated. When a serious illness strikes, we want to treat the disease. We want to make it go away for as long as we can. We want to slow it down if we can't make it go away. And we want to minimize the way it impinges on our ability to do what matters most to us. We want to make good functioning and quality of life, and we want to have our care be coordinated and have a good connection between our caregiving teams. We want to have support to help us make informed decisions that are the right decisions for us. Next. So when we think about how the healthcare system meets these challenges, we realize that our healthcare system, as it's evolved today, really focuses more on sick care than health care. And it's very driven by technology and diseases and unfortunately often undervalues the importance of the patient's quality of life. Until very recently, physicians were not trained to assess pain or symptoms or distress in patients with serious illnesses and to adequately address address those pain, symptoms, and distress. Other healthcare providers like nurses or social workers may have had some training to address some of them, but working together as an interdisciplinary team was not really part of anyone's training. We realize that we can do better and we need to do better about these issues that are so important to patients and survivors. Next. The oncology world as well recognizes how important this is, and ASCO, which is the American Society for Clinical Oncology, the professional society for oncologists in all disciplines, had issued clinical practice guidelines recently that stated patients with advanced cancer, whether they are inpatients or outpatients, should receive dedicated palliative care services early in the disease course, concurrent with active treatment of their cancer. Referring patients to interdisciplinary palliative care teams is optimal, and services may complement existing programs. Providers can refer caregivers of patients with early or advanced cancer to palliative care services because the stress of these serious illnesses affects not only the patient, but everyone who's in their world, their family caregivers, and people who are loved ones. Next. Unfortunately, public awareness of palliative care has been low. When the Center for the Advancement of Palliative Care did a survey a few years ago in conjunction with the American Cancer Society and the Cancer Action Network, we saw that 70% of people in the general public were not at all knowledgeable about what palliative care was. Only 5% were very knowledgeable. Next. But once people were informed what palliative care was, 92% would be likely to consider palliative care for themselves or their families. 92% believe that patients should have access to palliative care throughout the country, and 95% said patient and family education about palliative care as part of their treatment was important. Next. Excuse me. With regard to palliative care and its role in the patient with ovarian cancer, quality of life is most affected by the symptoms that patients experienced. Ovarian cancer often presents in patients who have later stages of disease, and a heavy symptom burden has traditionally been due to a combination of disease and its treatment. The early integration of palliative care and new disease-focused therapies with collaborative care of ovarian cancer patients can lead to improved outcomes and improved quality of life throughout the course of disease. Next. Now let's move on and talk about some of the most commonly asked questions when people are learning about palliative care. Next. When do you need palliative care? So that's one of the most common questions, and palliative care is really based on need, not on prognosis. It's really for patients at any age and any stage of disease, and can be provided along with disease-focused and curative treatments. Palliative care is really for the patient who has symptoms that are impinging significantly on their quality of life and their ability to do things that are important to them. So palliative care is for people in need of relief from pain, symptoms, and the stress of serious illness, and whose goal is to improve the quality of life for both themselves and their family. Next. So what we want to do is provide those who are dealing with cancer the best of what oncology has to offer in terms of disease-targeted treatments, and at the same time, provide those dealing with cancer the best of what palliative care has to offer in terms of symptom management and quality of life, so that we are improving survival while maintaining the highest possible quality of life. Next. So what's the impact of palliative care for the patient with ovarian cancer? It improves and relieves pain and symptoms. It may help patients live longer. And that data really comes primarily from studies that were done in patients who have lung cancer, but we have significant reason to believe that it may apply to patients with a variety of other kinds of cancer, although that specific research in ovarian cancer patients has not yet been done. It provides better family support, can reduce the length of hospitalizations and the number of hospitalizations and emergency department visits, and reduces unnecessary tests and procedures that may be unpleasant for the patient to go through and may not contribute to their overall success of their care. Next. Can a patient have palliative care and still have their cancer treated? Absolutely. And that's really one of the most common questions that we have. And the misconception that this is an either-or choice rather than a both-and option is really one of the most common misconceptions. And I hope everyone will leave today's webinar understanding that this is not something you have to choose between. Next. So how does this happen? Do you bring it up to your doctor, or do you wait until the doctor brings it up? Well, either one can happen, but certainly if you think that you would benefit from palliative care, if you have symptoms that are significantly affecting you or feel like you want to find out whether palliative care might have something to offer you, you don't need to wait for your doctor to bring it up. Most people wind up asking their doctor for a referral to palliative care. But palliative care teams are specialists, and it is important for the primary doctor who's treating the patient's illness, or nurse practitioner, the primary provider, to call in the team and understand that the team is going to be involved and that all the care provided being done in a collaborative fashion. Next. So who exactly is this team that's providing palliative care? So the core team usually is made up of physicians, nurses, social workers, and chaplains, but there may be additional team members who are participating, people like music therapists, physical therapists or occupational therapists, speech therapists or dietitians, other creative arts therapists, and child life therapists. And palliative care can be provided really in any setting where the patient is, an inpatient stay in a hospital, a rehab center, an outpatient clinic, or at home. Next. So how do you get a referral to palliative care? If you're suffering with pain or other symptoms from your cancer or its treatment, you should ask your doctor whether there's access to palliative care where you're getting treatment or in your community. Explain that you could benefit from an extra layer of support. You can go on the getpalliativecare.org website, and you or your family or your doctor or nurse practitioner can find a local team through the provider directory there. Next. So getpalliativecare.org is really a tremendously valuable resource for patients and families. It's a clear and comprehensive website on palliative care. It includes a definition that I shared with you, a 5-question quiz so you can relatively quickly and easily assess whether palliative care might be helpful for you or the patient who you're looking into it and investigating it on their behalf. You can find out how to get it if it's right for you. And also some tips and coaching on how to talk to your provider, your physician, or your nurse practitioner about palliative care. There are real stories through 3 free podcasts. There are informative webinars like this, and there's a provider directory that's searchable by location. You can download the What You Should Know handout for patients and families so that you can share the information that you've learned with the others who are important to the patient. Next. So we're really living longer than ever before with ovarian cancer and other serious illnesses. And patients often have symptoms that need to be addressed by specialists, and they're not addressed by their oncologist or their primary doctor. And I'll add that this also applies often to survivors who may have long-term effects of disease or its treatment, even if their disease has been able to be put into remission and stays away for a long period of time. And sometimes in some programs, survivors are also getting care from palliative care teams in addition to patients who are actively undergoing treatment for their cancer. The cancer and the symptoms can and should both be treated. Palliative care improves the outcomes for patients, and I'll add survivors facing serious illness, and their families as well, and caregivers. Patients and family members can ask for palliative care. Next. So you can go to getpalliativecare.org to get more information and visit the website. Next.
Thank you all so much. Dr. Pop, we're going to now begin our Q&A session. That's okay
Great.
with you? Again, for everyone that is joining today, if you'd like to ask a question, simply type in your question in the Q&A box at the bottom of the display panel and click send. Our first question is, will I see a palliative care doctor at the same time that I have regular appointments with the oncologist?
So that's an excellent question. It varies a little bit depending on how the palliative care team is set up. Where I practice, I see patients in the cancer center. So we often will coordinate visits with when the patient is coming to see their oncologist or coming for treatment. Sometimes the palliative care team is located in a different location, and they may that may make it better to have visits separately. And I do have patients who sometimes feel like 2 visits in the same day or treatment and a visit with me is really too much for one day, and they prefer to see me on a separate day from when they're coming for treatment, especially if the treatment may involve some long infusions. So I think it's really something that is a little bit specific from location to location. And sometimes when patients are getting long infusions, they're in a relatively private space in the infusion area. So I may wind up being able to come and see them in the infusion area where they're in a bed during their treatment and have some privacy to talk and be examined. So there are a lot of different options for how care with the palliative care team and the primary oncology team can be coordinated.
We have another question. Why hasn't my oncologist told me about palliative care?
That is an excellent question, and it's one that's quite difficult to answer because it's very hard for me to know what's in your oncologist's thoughts. So just like many lay people are not fully informed about palliative care, but once they know what it is, they very much want it for themselves and their loved ones. Because palliative care is a relatively new specialty, not all physicians or healthcare professionals are as fully informed about palliative care as those of us in the field would like. And it may also be an issue about what accessibility is in the center where your oncologist is practicing. And that's why we recognize that oftentimes the patient is the person who's bringing it up, and we want to make sure that patients are well equipped with information about what's available in their area, and they can go to getpalliativecare.org and find out what resources are available in the geographical area where they are and provide that information to their oncology team.
Okay, we have another question. Great, we have so many questions coming in. So will the oncologist and palliative care doctor be seeing me at the same time? And how does that work when you say it's coordinated?
So occasionally we will do joint visits. at least in the site where I work and other places where I've practiced in the past. More often, they are not joint visits, but sequential visits. So either the oncologist will see the patient and I'll see the patient after that, or vice versa. But we speak to each other. We send each other emails. We have a shared electronic health record, or we send a note through fax or email so that both of us know what the other one is doing. It's important for me as a palliative care provider to know if a patient's treatment is being changed, either because the patient's had side effects or because the disease is not responding to that treatment anymore and it needs to shift, they need to shift gears to a new kind of treatment. And it's important for the oncologist to know what medications or other recommendations I've made about trying to keep the symptoms under control. So that's how we both coordinate visits and share information so that we're working in a collaborative fashion to help the patient and their family.
Is there a culturally appropriate approach for patients who have language and cultural barriers?
Oh, that's really an excellent question. So the kinds of things that we address in palliative care in terms of how these symptoms are experienced by patients are very, very deeply personal for each of us. And because there's an enormous amount of thinking and ideas from our cultural backgrounds that influence how we think about health and illness, cancer, pain, other symptoms, treatment, medical care, it's very important to develop a relationship with the patient and understand what these things mean to them so that we can address what's important to them in a way that's relevant. These are often very nuanced conversations, and it's vitally important to use translators. And hospitals and outpatient centers are usually required by the accrediting bodies to have access to professional translators. We have some on-site translators and interpreters for the languages that we commonly experience, our patients' primary languages, and that varies a lot from location to location. There are, places in California where Hmong is a very common language. I haven't had any patients who speak that language. In the parts of New York where I'm working right now, I have a lot of patients who speak various Chinese dialects and also a lot of native Spanish speakers. But we get patients who speak a huge variety of languages. And being able to have someone who's a skilled interpreter who can help make sure that these nuanced conversations are carried out in a way that the palliative care team understands what the patient is trying to express and the patient understands what the palliative care team is trying to express is really extremely important.
So we have another question. There's a social worker when I meet with that I meet with when I go to the oncologist's office. Is this palliative care?
So it may be an element of palliative care, and it may be the most important element that a person needs at various points in the course of their illness, depending on what their concerns are. And one of the things that's really wonderful about the way the interdisciplinary palliative care team functions is that we know what we know, and we also know what the limits of our skill sets are. But we also recognize that the patient may have needs that are outside of our skill set. So I have a series of questions that I routinely ask when I meet a patient for the first time that help me know whether or not I need to get the social worker involved right away, or the issues that the social worker might be most helpful in addressing with the patient are not a high priority right now. Similarly, we screen for spiritual issues to know whether or not the patient has some concerns that would be best addressed by a chaplain rather than by a physician, or a nurse rather than by a physician. And if the first person from the palliative care team that a patient or a family member meets is a social worker, a similar process happens where the social worker will be able to ask some questions that help him or her know whether or not the patient needs to see a physician for physical symptom management or a chaplain, etc.
What if I ask for palliative care and the oncologist says that it's not necessary?
That is a really good question. So I think that can be something that's challenging, and I think part of it depends on your relationship with your oncologist. And I think ideally it would be a good time to ask your oncologist to help you understand why they think that's the case. And if you really want it anyway, ask them if they will indulge you and let you go anyway. And if you decide after you've met the palliative care team members yourself that it's not something that you need right now, then you've invested your time and effort in going to an appointment, and maybe you've invested a copay for an office visit, but otherwise you're the one who's made the investment of your time and effort, and it hasn't done anything that's problematic for the oncologist. And that's really probably the way that I would try and approach it. And if the oncologist has a particularly good reason, although it's hard for me to think of what it is other than that they're worried about squeezing it in if somebody's having a very intensive treatment regimen and the palliative care team isn't easily accessed on the same site where they're getting radiation treatments every day or something like that. It's hard for me to think of why at least an introductory visit wouldn't be helpful and would be strongly opposed by an oncologist.
We have a few questions coming in about insurance. The common theme is it always covered by health insurance?
So those are great questions. In general, in the outpatient setting, palliative care is really treated like any other specialist visit. So whatever rules would apply to you going to see a cardiologist or a heart specialist or a nephrologist, which is a kidney specialist, would apply to you seeing a palliative care specialist. We use analogous kinds of codes for our office consultations and follow-up visits as they use for theirs. Sometimes people are in insurance plans where they have to have referrals and authorization for seeing specialists from their primary care providers, and other times they're able to see anyone who's in a network. So it's really very analogous to any other kind of a specialist. That's something, the issue of insurance coverage is something that's been of concern as palliative care, which is really a very young specialty. It's only been recognized formally as a medical specialty for less than 20 years, which in the history of medicine is a relatively short period of time. And we make sure as we train new palliative care specialists that they understand about these issues in terms of access to care for patients and know how to provide palliative care in ways that are in concert with what the patient's insurance coverage is. So I think there are fewer and fewer obstacles, but they're often analogous to, the obstacles that remain are often analogous to the obstacles that exist for seeing other specialists. I'll just add, there are really sorts of three things that we do in palliative care, especially in the outpatient setting. The biggest one that I talked about was symptom management. We also provide an extra layer of support, and that can be around decision-making when people are at a key crossroads and having to make an important decision about changing treatment or embarking on a new course of treatment, or if cancer has returned after a long period of it being quiescent. And we can be helpful in those periods of time. We also can be helpful when people are trying to begin thinking about the future and want to make a plan for situations that may face them in the future, being prepared if there would ever be a time when they were so sick they couldn't make decisions for themselves, making sure that someone else is empowered to make those decisions on their behalf and has all the legal rights to make treatment decisions that are in concert with their personal goals and values. Or if they live alone and they're concerned about a time when they might not be able to take care of themselves, living alone, either temporarily or permanently. And so that kind of advanced care planning and decision-making is specifically reimbursed by Medicare and many kinds of insurance when that's the reason for the palliative care team's involvement and the primary work that the patient and the family and the palliative care team are doing together. So that's a different issue, but I think an important one to raise with regard to the issues of insurance coverage and access to care.
How exactly will palliative care help my family?
So that's a great question. I think it depends on what the family's needs are. So sometimes families struggle with the responsibilities of caregiving. We read a lot in the popular press about the sandwich generation. And when the patient is a grandparent, then sometimes their children are dealing with their own children's issues as well as trying to be a good caregiver for a parent who has a serious illness. And that can bring on a unique set of stressors. And the palliative care team, often in particular the social worker, can help with that. Sometimes managing the physical symptoms that the patient has can relieve the stress that the family members are having, because it's difficult to watch someone who you love and care about feel unwell and uncomfortable. And when they're able to feel better because they have better symptom control, that in itself alleviates the stress that family members have. And sometimes family members and patients aren't exactly on the same page about decisions that need to be made, and that can be stressful. So sometimes the palliative care team can help work with the distress that's related to that. So there are a variety of different ways depending on what the issues are that are causing stress to the family members that palliative care teams can help. And those are a few of them.
Just a reminder, if anyone has questions, please write them in the chat section. We have some more. One of them is, can you please share a story about a typical patient that you've helped who has ovarian cancer, so that I could really understand how palliative care works?
Sure. I just have to think for a minute so that I tell the story in a way that protects the patient's privacy. So I have a patient who asked to come see me primarily to do advanced care planning. And she was someone who lived alone. She was an intensely religious person. She had actually had a religious vocation, had served as a nun, although she was no longer living in her vocation at the time she came to see me. But her faith and spirituality was an intense part of her life. And because of the many years that she had lived as a nun, she was not married and had never had children and was living alone. And she had some struggles with what it meant for her to have this serious illness after she had lived the life that she had. She had some significant physical symptoms, and she had some very strong ideas about ways that were and were not acceptable to her in addressing them. And she really wanted to make sure that there was a plan for how she could be in an environment where her very intense faith would be respected and supported and integrated into her care when a day came at some point in the future when she couldn't live by herself in her own apartment alone. And so we worked together, seeing each other probably once every month or 6 weeks, coordinated with when she was coming to get her treatment in the infusion area or seeing her oncologist. We helped make sure that she identified someone who she trusted and who understood her strong beliefs about treatment of her symptoms, as well as her spiritual orientation and how important that was to her, who could make decisions if she ever lost the ability temporarily or permanently to make decisions for herself. And we developed a plan for where she would want to be receiving care, where she would have the degree of independence that was important to her when she couldn't live alone in her apartment anymore. And we did all this work throughout the time she was getting treatment. We helped her with a lot of information about future decisions that she might face, because her oncologist had shared with her that her treatment was eventually likely to stop working, although when we first met and for a number of months afterwards, it was working very effectively. And when she developed more difficult symptoms, and it became clear that the original treatment was not working, we worked together thinking through whether she would want to try a different kind of disease-directed therapy or not, managing her symptoms in a way that minimized her time in the hospital. She needed to have a procedure to drain some fluid that was causing a great deal of discomfort. And the first time that was able to be done, because we had done this planning in advance, and we knew what was most important to the patient with a one-night hospital stay that was not long before Thanksgiving, and it was important for the patient to be home for Thanksgiving and be able to celebrate Thanksgiving with her family. And she continued to get care. We brought services into her home so that she could continue to live there as long as possible. And she needs to have that procedure repeated, and we've been able to arrange to have it done as an outpatient so that she doesn't even need to come and stay one night in the hospital, which is something that she, like most people, finds quite unpleasant. And I continue to be in touch, even though I'm not able to make home visits, with the doctors and nurses who are able to, who are making visits into her home to help continue to coordinate her care, because she's now, unfortunately, at a point where it's increasingly difficult for her to come see me in the office. But because we have this strong foundation, we're able to do that work.
Great, thank you. Another one is, how long would the palliative care be part of my care?
So that's a great question, and the answer is for how long you need it. I have patients who get palliative care when they first find out about their cancer because it's causing a lot of symptoms that lead to the diagnosis. And we, once their disease-directed therapy really starts to do its good work, their symptoms are well controlled and they don't need what we have to offer for a period of time, and I won't see them for months or even years. And as disease has a very variable path, there may be different times over the course of their illness that they need to see me again because either symptoms or psychosocial concerns are more prominent and more impactful. And so it can come and go. And there are other patients who we see them throughout the course of their illness. So it really depends on what's helpful to the patient.
So we have a few more. One is, can you please address the use of psilocybin for anxiety?
So that's a really interesting question. Psilocybin is a substance that causes people to have hallucinations. It's somewhat related to LSD. It's derived from a mushroom, and it is not considered a legal drug, I believe, in any jurisdiction in the U.S., but there is some research that's going on looking at what we call existential distress, which is an intense psychological distress around having a serious illness. And there are a few specialized centers. It's not being done, to the best of my knowledge, in our institution, but there is one other place in New York that's doing it, and also I know of a researcher on the West Coast who is doing some research on this topic. It's very complicated research to do because of the Drug Enforcement, the administration, the DEA regulations around psilocybin. So that's really, the research is of interest and may prove to be helpful, but there's a lot we don't know yet. And I would, if someone's interested in that work, I would just say that they should see through research on the internet if there are clinical trials going on in their area, and look into it from that standpoint. But it's all experimental treatment at this point that I'm aware of.
How is palliative care different than integrative medicine?
That's an interesting question, and I'd say that it sometimes includes integrative medicine, but also is often using a lot of conventional things. So integrative medicine is often using, some people often refer to it also as alternative medicine, although integrative medicine is really a much better term when it's done in conjunction with conventional medical therapy. So it's using a lot of mind-body techniques and things like acupuncture, for example, or Reiki, some elements of Eastern medicine, in conjunction with Western medicine, so medications that are FDA approved or under research trials, and sort of the conventional kinds of medical treatment, medications, radiation, surgery, in a conjunctive, adjunctive, combined fashion, which is why we say it's integrated in. So I think that the access to those therapies is really quite variable. They are part of some palliative care programs, and when they're available, I think they're definitely worth exploring. Most of those therapies don't take anything away and can add something, and they're often very low risk, although not exclusively, and it's definitely something that each patient should discuss with their own physician about whether there are any specific risks that are unique to them, knowing what their illness is like and what specific treatments they're getting. But it's wonderful when palliative care programs can integrate a number of these other therapies in addition to medications. The biggest obstacle, as is unfortunately often the case, is that those are often not reimbursable services, and so it can be difficult for a palliative care program to support their being included. But we have a few of them available in our site, and the patients find them extremely helpful.
The question came through, I feel so overwhelmed with this diagnosis. I already am seeing a therapist, but what would a palliative care doctor add to help me?
So that's a great question. And I think sometimes the palliative care team can provide some coordination and take some things off of your shoulders, depending on what's at the root of the sense of feeling overwhelmed. And sometimes that can be one of the few situations where we may not be helpful. We may just be one more doctor's appointment, and when you're feeling overwhelmed, that may not be so helpful. So I think it's helpful to explore in a more specific way with your care team if it might be helpful to you and your therapist. But I think that we do want to make sure that we are doing what we do in a coordinated way in conjunction with the other people who are part of the team, and that we're not being sort of one of too many cooks in the kitchen.
We have two questions about pain. I've seen a pain doctor. Is that the same as palliative care? And then another question is, I have nerve pain from the cancer treatment and the oncologist is trying to help, but it's been going on for a long time. Should I go to a palliative care doctor?
So those are, it's helpful that you bundled those two questions together, Melissa, and those are both very good questions. So I think palliative care physicians and nurse practitioners, palliative care teams in general, have a lot of expertise and experience treating pain that's related to cancer and cancer treatment. And there are a number of medications that are used to treat ovarian cancer that can cause nerve pain. So it's definitely something where we can be helpful because pain is such a common part of cancer illnesses. There's lots of experience and expertise that many oncologists have, but just like a primary care doctor can take care of some diabetes, but sometimes he needs or she needs to call in a specialist who's an endocrinologist, or some heart problems can be taken care of by a primary care doctor, and other times a cardiologist is helpful to weigh in and offer an opinion. I think it's really analogous with palliative care. Sometimes it's helpful to get an opinion from the palliative care team, and it may be that they'll say, what you're doing is all the right things, and you should just keep doing it. Or they may say, oh, we have a really different new idea. Why don't we try that? And if it helps, great. And then, do that in conjunction with the primary oncology team. So in summary, to answer sort of both of those questions together, there are lots of pain specialists who aren't palliative care specialists, and they may not understand the other issues that are part of the serious illness, like cancer. But palliative care physicians and nurse practitioners and the whole palliative care team are really skilled at looking at the symptoms as they're a part of the overall illness. So they'll address pain as part of the overall treatment. And if a particular symptom that the oncologist is trying to address isn't going as well as you think it might, it's certainly worth asking a question whether it would be helpful to get an opinion from a palliative care specialist.
I'm just starting treatment, but palliative care has not been raised. Should I ask for it or wait until I have specific symptoms?
So that's a great question, and I think it's really a way in which the field is changing and evolving. There is the research that I made reference to that really comes from treatment of patients with lung cancer suggests that patients who get referred to palliative care as soon as they're diagnosed and continue to have intermittent visits with palliative care teams over the course of their illness and treatment do better than patients who only get referred to palliative care when they're having significant burdensome symptoms and their oncologist suggests it. We don't know how that model of early palliative care referral will play out in patients with other kinds of cancers other than lung cancer. But there's certainly reason to believe, and my experience certainly suggests that having a visit with a palliative care team to begin to establish a relationship and to get to know one another so that you can feel like the palliative care team understands who you are and what's important to you, since managing these problems are very personal and individualized, can be helpful, and it can be done in a way that's not terribly intrusive. When you're early on in the course of illness and feeling well, you don't want to spend a lot of time making visits to a doctor's office. You want to spend time living your life and doing the things that are important to you. So kind of trying to find what's the right balance for you in terms of early establishment of a relationship with a palliative care provider versus waiting is something that I think we don't have full evidence about. And part of it depends on sort of how each person in terms of patient and family are sort of psychologically put together in terms of, do they feel better knowing that they have a relationship with the palliative care team and they're sort of on retainer waiting to be called in if there's a need? Or would they like to just wait and call them in early on in the course of a problem developing? So no right answer, but a lot of options.
So we have time for probably 2 more questions, and I have a few here. One is, I actually asked for palliative care recently, but was told by my doctor that it's not available. What should I do?
I would probably ask for clarification of what that means. Does that mean it's not available in the center where you're receiving treatment or in your geographic area? There are parts of the country where there are shortages of palliative care providers, and while there's been enormous expansion of palliative care, it's not available everywhere as fully as we would like for it to be. And because there is, it's a relatively new specialty, there is a workplace shortage, and some palliative care teams, unfortunately, do have to limit in some fashion the patients who they care for at any given time because they can only do a good job. But the best thing to do would be to go on getpalliativecare.org and put in your zip code or your geographical location and find out whether there is something that's available in your area. It could be that there is and your oncologist doesn't know about it, and you could help teach them something really important about a resource in your community and help all the other patients in your area by sharing that information with your oncology treatment team if there is something available in your community. And if there isn't, you can find out what's closest and whether that's feasible for you. And you can, if you're feeling up to it and have the energy to get involved, try and work on making sure it's available to the people in your community who may need it at some point or another.
Just to go off of that, someone asked, if I'm not admitted to the hospital, can I still have palliative care?
So that's a great question. Palliative care can be provided really in any location where the patient is. That said, there is some geographic variability, and each health system often has some variability in terms of what's available within that particular provider network or hospital or health system. We have, for example, outpatient palliative care available in 3 sites in Manhattan, but we have 2 sites where it's not yet available, and we hope that it will expand there eventually. So we know that there's some variability in terms of access in the outpatient side. Much of the initial growth in the field was on the hospital-based palliative care, but there's more and more growth in outpatient palliative care, and if it's not available where you are now, I think you'll find that it will be soon.
Okay, we have a few more minutes. Is massage therapy part of palliative care?
So again, it's kind of like the integrative therapy that we talked about a few minutes ago. It definitely can be, and I think that for certain kinds of both pain and stress, massage is a wonderful adjunct to medications that we may use, and in places where massage therapy is available either separately or as part of the palliative care team, it's a wonderful avenue to explore. We're fortunate we actually have a massage therapy school that trains massage therapists near where we are, and they will often send their students to help work with our patients. And patients really love the fact that they can have a way to address pain and stress that doesn't necessarily involve another pill. And the side effect profile of massage therapy is usually zero. So it's great when it can be included in palliative care.
And we have time for one more question. I'm not actively in treatment anymore, but I'm struggling with a bunch of symptoms that I think are because of the cancer. Should I seek palliative care, or is there a different avenue that I should take?
So that's really a great question. That's something that is often very location specific. So when people are finished with disease-directed therapy, they're kind of in a place where either their issues can be addressed as part of a cancer survivorship program. Sometimes the palliative care teams provide some of the survivorship services because they're related to symptoms and long-term effects of cancer or its treatment. Sometimes that's a separate team. And so I think it would be worthwhile speaking with your oncologist and cancer care team and not necessarily waiting until your next visit, because oftentimes when you're not receiving cancer treatment, the follow-up visits are relatively spread out. So you could give a call and just ask what resources are available in terms of symptoms related to survivorship, and see whether that would be something. Again, because palliative care teams are often stretched to meet all the needs of the patients receiving active treatment, they may limit their ability to see patients who are receiving active treatment and not have the capacity to see cancer survivors. And other places, cancer survivors are seen by the palliative care team. So it's a great question and an important one, and one that I hope your oncologist will be able to get you a good answer to in your area.
Okay, well, that is all the questions that we have time for today. Thank you everyone for your wonderful questions. It was very engaging. And again, thank you for joining us. And a very, very special thank you to Dr. Beth Pop for that informative discussion.
It was my pleasure to be here, and I really appreciate the thoughtful questions that everyone who's watching the webinar sent in. And thank you to the staff from CAPC for all your behind-the-scenes work and for making this possible for the participants.
Of course. Well, we look forward to our next webinar. Thank you so much.